variety of fields and making an impact every day. We are so proud to host the annual Kovner-Behrman Forum. It's one of NYU Wagner's premier events, and it's made possible only by the continued leadership and dedication of Professor Tony Kovner. Tony created this forum 23 years ago in honor of his mother, Natalie Lieberman, who made the series possible with a very generous financial gift in honor of her son and of her own parents, Dr. and Mrs. Percy and Eva Behrman. Many of you in attendance here have also given contributions that have helped us sustain and grow this series over the years, and we are very grateful to you. Tonight's event focuses on a timely and critical topic, public health care. Unfortunately, in the news again today. I would wish it would be in the news a little less one of these days, so we could just do it. But here in New York City, the healthcare landscape continues to present complex challenges for both healthcare providers and for residents. Despite increases in the number of New Yorkers who have health insurance, there remain more than 500,000 residents who are uninsured, and they often cannot afford the care that they need. As a result, the role of public health care services, our public hospital system in New York City's communities, has never been more important. As we look forward toward improving health care and health for all, we want to learn about the key opportunities and threats that one public health care system, the New York City Health and Hospitals, faces. And how does New York City's healthcare landscape compare to those for public health care in other places around the country? Tonight, you'll hear from one of the nation's leading experts on these questions, Dr. Mitchell Katz, the President and CEO of New York City Health and Hospitals, who will be presenting the main priorities for the organization in the near term and tell us about what the system's plans are to achieve these priorities. Responding to Dr. Katz will be Dr. Bruce Siegel, President and CEO of America's Essential Hospitals, and Dr. Joe Ivey Boufford, former Dean of NYU Wagner, and many other things, but currently Clinical Professor of Global Public Health at the NYU's College of Global Public Health. And I'm also delighted to welcome Dr. Jose Pagan, Chair of H&H and Chair of the Department of Health Policy and Management at the College of Global Public Health, as well as many others of you in the audience. Tonight, you will hear about how systems are setting priorities to address challenges and finding opportunities to meet their missions of providing health care for our nation's most vulnerable populations. It's my pleasure now to turn this over to Dr. Katz.
Well, thank you, Dean, for the nice invitation here. I'm so glad to see all of you. What an amazing group of people you are. You didn't mention that Joe is also not only a prior dean, but she's a prior health and hospital director, CEO and president, as was Dr. Siegel. So I have to be careful what I say because there are two people who held the job previously. There are so many great things about health and hospitals that I could talk to you about. It's an organization with an amazing tradition, right? Bellevue Hospital established prior to the signing of the Declaration of Independence, a system with a tremendous heart, a system very much unlike the systems I ran in LA, San Francisco, where my doctors and my nurses actually look like my patients. Something that I really love about health and hospitals is that the neighborhood focus results in people who work at Harlem live in Harlem, and people who work in Spanish Harlem live in Spanish Harlem, and people who live in Central Brooklyn and work at King's. And you know that's an amazing feature. In LA, where I'm from, where I last worked, nobody lived anywhere near where they worked. Just as a matter of religion, you had to drive at least an hour to your work. But it's an amazing organization. 20 minutes isn't anywhere near the amount of time that I could spend telling you about all of the amazing things or, all of the tremendous challenges of it. So what I want to focus on is the mayor's initiative of NYC Care, because I think it really sums up what the Wagner School is about, which is putting theory into action. And on the way, I think it hits a lot of issues that we're grappling with is, what is the role of a public option? What is the role of universal health care? What systems could create that in New York, in the US? What kind of health system do we want? What do we do about the uninsured? So start with just some general New York City facts. So there are approximately 600,000 people in New York City who do not have health insurance. 300,000 of them are eligible, but they haven't applied. So they're eligible for the essential plan, for Medicaid, or for something on the exchange. Many of them are likely young invincibles. They don't see the need, or they feel, oh, I'll get stuck with large, co-pays anyway, or deductibles. I don't like to fill out paperwork. People who don't know don't open their mail. That probably constitutes most of the 300,000. Part of that group, though, is also those who would join, but they can't afford it because they're in a group where it's not a large enough subsidy for their level of income. The other 300,000 are people who are undocumented in this country, and they're not eligible for insurance. And what the statement that the mayor made, which I think is great and I very much believe in, is that everybody should get care. Right, and I say get care rather than get insurance, because much as I believe in insurance, and the ACA has made a great step forward in our country by covering more people, insurance is not care, right? Insurance is at best a vehicle for paying for care. Insurance is about money, right? It's about how you transfer money from different entities, and sometimes on the way, sadly, make money. But it isn't care, right? What we really care about is, do people have a doctor? Do they have a nurse? Do they have a social worker? Can they get their medicines? Is there a pharmacist? Are there people who are going to heal them, talk to them, help them? That's what we really care about, and insurance is just the vehicle that enables that to happen in the U.S. So for that 300,000, what we have said, and the mayor has promised, is we are going to guarantee them care. We're going to make sure that every one of them can get to see a primary care doctor in a timely way, can have outpatient specialty, can have the medications they need, the laboratories, the radiologic services, the emergency services, hospitalization. Now, people who have labored in health and hospitals, like Joe, Bruce, others of you who've worked here, Luis is here, I noticed. I says thank you for coming. We'll say, well, but hasn't health and hospitals always done this, right? Isn't the great thing about health and hospitals that we've always cared for people? I see Judy shaking her head. It's the proud tradition, without regard to income or insurance or immigration. And the answer is yes, but you have to ask yourself, how did we care for them? And this is where it bleeds into the other issues. We said, go to the emergency room. That's what we did. You're sick, go to the emergency room. You have a lump in your breast, go to the emergency room, right? That's the vehicle by which health and hospitals has operated. And yes, the good thing about health and hospitals is that when you went to the emergency room, we didn't make you feel bad that you were poor. We didn't make you feel bad that you were homeless. We had translation available. We had lawyers available. We had food stamp enrollers. But what we've never had is a robust system where you can see a primary care doctor, where there are reasonable waiting times for primary care, reasonable waiting times for specialty, where you have the services that one would have with insurance. So you can go and get your antibiotic prescription, but if it's Friday night, where do you go to get that filled currently? And the answer is, we don't fill them. Now, sadly, and this is where it all bleeds into other issues, just last week in my clinic at Gouverneur, I saw an insured patient who got a prescription for an inhaler that he didn't fill. Why didn't he fill it? Because the copay on his insurance was $60. He didn't have $60, right? So, these issues are not necessarily all unique to people who are uninsured. But what we're really envisioning is that we're going to take what was, a promise that if you come for care at one of our facilities, we won't send you a bill, and instead turn that into meaningful relationships that people have with primary care providers, pediatricians, adult doctors, geriatricians, psychiatrists, and that then translate to a whole set of services. And to do that in a way where people are also given a card that defines their membership, who their doctor or nurse practitioner or physician assistant is, right? In a room of informed people like this, when I say health and hospitals has always provided these services in a culturally appropriate way, people nod their heads. But think to yourself, well, but how would a new immigrant know that, right? How would you, yes, we have actually, quite an amazing array. And I would say, as someone who ran the public health delivery system in both San Francisco and Los Angeles, New York's array is much more impressive in terms of what we have to offer. But how would you know it? And our system is full of catch-22s if you actually try to get your patients the services they need, even though we're full of people who really want to deliver the services that people need. But we've had a few years too many of the kinds of bureaucracies that make it too difficult for people to just get what they need. A lot of, when I think about health and hospitals, what's important to me is that everything is about people's relationship with their care providers, whether that's a doctor or a nurse, or sometimes it's a case manager or a receptionist. It doesn't matter. Healthcare, when it's done right, is about relationships, because the rest of the stuff you can look up in books, right? What you can't look up in books is the healing effect that a positive relationship has. And that's certainly something that I think low-income people are often in systems where they're not getting people who are really trying to care for them, help them, and are particularly appreciative when someone puts the system together. So we start running in South Bronx. We chose South Bronx because on any measure of healthcare status, and those of you in the school know this, South Bronx does the worst. And so that we're beginning by expanding the number of primary care doctors for the first time, certainly in recent history. Today, if you were a new patient and you needed a primary care doctor, I could get that for you in a week or two. But as the program grows, I'm going to need additional providers. Then we figured out next level how many specialists that will translate to. Those of you on the finance side, may remember that people said, well, how could you possibly do this for $100 million, which is what the mayor committed to the program. But the answer is that the money is in the system, because when people don't get primary care, they still wind up coming, right? Because when you need to be admitted, you need to be admitted. When you need to go to the emergency room, you need to go to the emergency room. So that the really expensive part of healthcare, the thing that eats up our healthcare dollars, it's not the part that I've just been talking about. Most surveys show that primary care costs about 5 cents of the healthcare dollar, right? The big bulk of the healthcare dollar is hospital, right? It's the hospitalization, it's the emergency room, it's the surgery, it's the drugs, right? And those things we pay for. And those things, when people wind up sick, they have no choice but to come forward. What we don't pay for, that most of us who have insurance can do, is you can call somebody on a Saturday and say, where do I go? I ran out of medication. And they'll tell you where to go, as opposed to, the historical answer might be go to the emergency room of health and hospitals, right? We don't have a provision, we don't have a pharmacy, we don't have a way of doing that, we don't have a way to get you into a primary care specialist. So, this is the program, I think, that gives us the chance to really define the future of health and hospitals as a primary care system with hospitals that care for people when they need that level of care. But otherwise, that's not where we send people first. And then more broadly, my vision about health and hospitals in general is, our mission is to provide quality care to all low-income New Yorkers who seek it from us. But what I really want to be is I want to be the culturally proficient provider for those people who have social determinant needs. And that's where I think we best fit in. You'll hear, and it's a true statement that other hospitals do take care of low-income people, and that's absolutely true. They do. But we are, for example, 60% of the behavioral health in all of New York City. So every other system does 40%. We are the only, Jen Havens is here, we are the only pediatric psychiatric emergency room in all of New York City, right? So we are doing the disproportionate amount, and why is that? That's because no matter how efficient you are, you can't break even on behavioral health. The payments don't allow. You can break even and actually make a margin on transplants, but not on behavioral health. And so, but that's okay with me. Those are my people. That's the reason that I got into public health is to take care of people. I've never, I'm always amazed when I drive around coming home from my parents who are still stuck in Rockland County. And there are all these posters, come to us, no, come to us, no, come to us. I've always wanted to take care of the people that nobody else wanted to take care of. Right, the idea of competing, trying to steal someone else's patient seems completely foreign to me. Right, my view is, well, but aren't there all these people who aren't getting any care at all? Right, like those should be the people that we want to take care of. And so, and we have a set of skills, our relationships with other agencies. They're the ones who are going to feed us a lot of, on the 300,000 side, those who can afford to get into NYC care, right? We're now working closely with the social service agency so that our enrollers are at places where people are going for general assistance. We're going to have people where we enroll people for food stamps, have people where we're taking care of children who are in either foster care or in families that need additional help, working with the correctional system and the probation system, and really marshal all of the city's resources to get the people who can be in insurance, get them in insurance, make sure that the rest of the people who are not in insurance are well cared for. They know where to go, and the where to go is not the ED, unless you have substernal chest pain or fall off a ladder and you really do need the ED. But it's primary care. For a young woman, it's a pap smear. It's culturally competent providers who know what the modern methods of birth control are. It's all of the things that people need to stay healthy in a system that really focuses on how can we be culturally proficient in caring for people who suffer from the social determinants of illness. So the two commentators are more interesting than I am, and so I'm going to end here and look forward to their comments. Thank you all.
Thank you very much, Dr. Katz. Dr. Siegel, come on up. Both of you come up. Both of you come up. Have some seats. It's fine. It's all good. Whoops. Whichever one. It's all good.
I was directed to sit.
You were directed to sit there. I would not want to. So I'm actually going to turn this over first to Dr. Siegel and just get your sense of Dr. Katz's remarks and where you think we ought to be going.
Oh, great. Thank you very much. It's wonderful to be here at NYU. Just to give you a little bit of history, as Mitch mentioned, I had the privilege of having his job briefly and not doing it as well some years ago, about 25 years ago or so, and I formed sort of this kitchen cabinet of people. I think Tony came in and out of that a few times as part of that, but we dubbed that kitchen cabinet, because it included some NYU folks, the NYU group. So this was often the location for our secret meetings and plotting. And it was an interesting time in the city then. We had an interesting mayor called Rudy Giuliani, who was not particularly enamored at that point of the corporation. So it was quite a time. Just wanted to make a few comments in response to your excellent overview of where the corporation is going. And I still call it the corporation out of old habit. Change is really hard. And I think the things that Mitch laid out are absolutely essential. They're absolutely critical not just for the New York City public system to thrive, but for the people of New York to have access to the very best health that they're entitled to. But making those things happen is by no means simple. I mean, it's hard in a small organization. Think about where you may work. It's hard in a small organization. Think about where you may work, even in a smaller organization. Then think about what it's like when you have how many employees?
45,000.
45,000 employees. And how many unions do you have? Have you lost count yet, or a lot? A large number. So you know, it's harder in simple organizations, and this is hardly a simple organization in any sense of the word. Given that, the other thing I'll say also is that often, and any management consultant will tell you this, culture eats strategy. So you can lay out the finest strategies, but organizational cultures may well resist that and may well undermine that. Now, I think the culture of HHC has changed a lot over the years. I think it's going to continue to change under your leadership. But when I was there, the culture was very much a culture of inpatient care. And Luis Marcos remembers that. Hi, Luis. How are you? Good to see you. Very much that was where the resources went. That's where capital was allocated. That's where the investments were made. And if you wanted to really, you know, rise up in the ranks, you rose up as being head of one of the general acute care hospitals in the system. So I think what you're laying out is a radical departure from that. I think it's exciting, but I also think, you know, it's going to be a tough cultural haul. And I'm sure you've already reflected upon that for the organization to really, you know, finally be able to embrace that and really change its value system towards primary care, towards social determinants of health, away from the emergency department, away from the horizontal patient. Now, I will say that I've been an observer of Mitch for the last number of years and had the pleasure of at least, you know, representing his system in Los Angeles back when he was at LA County. And as an observer, I'd say that he brought three skills that are going to be absolutely essential for this change to happen. One was focus. We used to make jokes around the office. You probably don't know this. We'd say, you know, we want to sort of get LA County interested in this and that initiative of ours at the national level. And then my staff would say, Mitch doesn't care about that. He's been very clear about what he cares about, which is the ambulatory transformation of the LA County system in a period of expanding coverage. And I think he drove that message incredibly powerfully and successfully for probably the only other system in America similar to the New York City system in terms of scale and scope and culture as well. With that came a very consistent set of messages, constantly delivered, repeated constantly, which can be very boring to a leader, leading organizational change, frankly, to constantly reiterate that. It's like being a political candidate. But he did that and did it successfully. And I say the third thing he brought, which will be so essential here in New York, is that I think he saw his role as not only as a driver of change, but also as a protector, as a shock absorber, as someone who saw their role as a buffer between the political leadership of the county or the city or whatever, and the thousands of people who made the system real every day. So I remember when reflecting a little bit upon my observations of you back in LA, and I think you're doing the same thing here, he had the ability to create a space for that change to happen by being able to manage the political realities. And, you know, managing the political reality of the mayor and the city council in New York is not easy. Managing the LA County Board of Supervisors is not easy. I think there's 7 of them, or 5 of them, I'm sorry, and I think they have on average about 2 million people in each of their districts, so they're larger than congressional districts, and they feel great ownership of the LA County system. So creating that space, I think, is absolutely critical, and I think that's obviously what needs to happen here as well. Last thing I'll say before I turn it back to Sherry is I'm very happy that you folks are all cleaning up the mess that Joe and I left behind over our years here. So, or at least the best I did. Anyway, but with that said, let me turn it back over to our moderator, Sherry.
Well, and I'm just going to turn it right back over to Joe Ivey Boufford, Dr. Boufford.
Well, good evening. It's great to be here, and to Tony, who has taught generations of health services managers and shaped the field in dramatic ways. It's lovely to see him. Um, it's hard to follow these two folks. I've been on the circuit with Mitch lately. He started out at the United Hospital Fund breakfast on Friday morning, I gather. I did not attend his budget hearings yesterday, but he's definitely all out there, which I think is a really important message for health and hospitals. One of the real issues is that I would say as a public system in New York City, it has not been taken seriously by the voluntary hospitals and has not been considered an important part of the voluntary system. And those of you that are students of public administration, public policy, will know that you need to have a good enough public health care system in cities for the voluntary hospitals to function. We've seen situations where health policy really turned that around, and I think it's a really important thing to remember. It's an important system, and I think Mitch is being so publicly engaged and engaging, as you've noticed for the last half an hour, and I think a great combination of expertise and personal projection of caring and engagement with patients and communities is really important, and that'll be a very important part of one of the things he will contribute. I want to say, I think the worst thing you can do is say when I was there, but I have sort of a funny perspective because I was with Health and Hospitals in 1982 to 1989 for 7.5 years, actually, in different roles, 4.5 as president. And then I came back on the board in 2011, I think, until last year, until Mitch was safely aborted. He said, "It's okay now, you can leave." And so it's made dramatic changes. And I think the other thing that is always dangerous about health in hospitals is people who, quote unquote, knew it when, assume it is the same now. And I think that does a great disservice to the work and the efforts that people who work there put in all the time. And so we have had initiatives in ambulatory care, and the financial system completely undercut them. And so I think these are really important issues. I know Mitch knows this, and I think the way he's approaching it is really important. But the alignment of the broader health policy and healthcare financing context is so crucial to sustainability of initiatives that we all think would make sense. So as Bruce said, we want to sort of get out of a lot of the hospital business, but a lot of the people who've done that over the years, Montefiore, for example, some of the large medical groups upstate, other facilities that have, quote unquote, done the right thing, the healthcare financing system has not kept up with them. So it's a real challenge, and we need to keep the advocacy going for health policy that supports the kind of changes that Mitch wants to see realized. The other thing I just wanted to say, two other things. One is I don't do healthcare anymore. I started out as a resident in the South Bronx in the 70s, and it was very clear to me that healthcare was a very, very small part of what my patients needed. So I've really moved over the last decade or more into dealing with the broader determinants of health, not the wraparound services that clinicians think about as determinants of health in terms of social services, housing, diet, exercise for an individual patient, but how do we change conditions in communities to which that patient has to return? We can do all we want to do in the hospital or in the examining room, and if we send the patient out to the same conditions, it's very hard to expect anything but the same outcomes. And so I've been working with the State Public Health Council for the last 10 years or more, trying to promote population health, the prevention agenda in the state of New York, age-friendly New York State. These are the things that people living in New York City don't really know what's going on in the rest of the state, which is great things go on in New York City, great things happen in other parts of the state. So I just wanted to mention that as an area that might be something people would be interested in exploring in the Q&A or not, as the case may be. But I think health in hospitals is uniquely connected to its communities, and many of the things, when Mitch gets this other stuff sorted out, I'm sure they will continue to be really important change agents in their community. They always have been, and they're well positioned to continue to do that. The other thing, sort of nodding to Tony on management, just to say a few comments on management. And we were talking about this before. I think Mitch is a fabulous communicator, as you can see, and I think one of my takeaways from any large system and the management in any large system, you can never communicate enough. When you think you have and you're dying and you want to stop and you're bored with what you're saying, just keep doing it, because somebody hasn't heard it, somebody doesn't understand, And I think what Mitch is doing is fabulous, because unless everybody in your system knows what they're trying to do and how they're contributing, it's not going to work. And he's started that really, really well, and I think it's really, really important. The other thing in public systems, I think the tendency is to think short term and not long term. I know people say, well, why would you have a strategic plan in a public hospital system? Because the mayor will change, the president will change. You have to do that because you want to set a professional base. They're like any other organization, and I think the challenge that Mitch has and that all of us have had is sort of balancing that. What would you do in a professional organization that wasn't a political, sometimes punching bag, sometimes tossing, it's a challenge, but it's a really important thing to remember. I think around the culture, people remember being treated as professionals, not thinking that, well, whatever the mayor says or political or somebody this, and that's a balancing act Mitch has to deal with that. People running voluntary hospitals don't have to deal with. The transparency in the public sector is an extra challenge and an excitement, and it's wonderful, but it's also challenging. And then one other thing, Tony's the founder of evidence-based management, and I think there are 2 points I'd say in H&H, which again I think are things Mitch has touched on. Evidence is certainly research, but it's also experience. And it's really important to honor the experience of people running institutions, delivering care, and also the patients themselves. And I've been really excited about that theme that you've raised over and over again, because the two together are indispensable in terms of deciding what to make change and how do you make that change that's going to benefit the people you hope to assist and support and grow with and partner with. And then the last thing I think in public sector management that's really important, and probably for everybody, it's really important to have an exit strategy. Because if you ever feel trapped in a leadership job or in a management job, you aren't going to be able to be effective. And I think that's one of the real challenges that we all need to think about in this. So I'll stop there. Thanks.
Thank you very much. I actually want to start off by picking up on a couple of the themes that that Bruce and Joe Ivey raised, and ask you a couple of questions. Can I start with that? And then actually I have the two of you chime in with the answers. The first question, I think, just putting a couple of things together, I think they raised questions around the alignment of the financial incentives external to the organization and the internal organization. How do you think about whether the financial incentives that you face on the outside are consistent or are propelling you in the direction that you want to go organizationally on the inside? And then I think there was another variant of that question, whether the incentives internally, the emphasis on inpatient care and the way that you get promoted, the sort of, all hospitals have this, that, the glamorous stuff in the hospital. How do you align that with again, this theme of trying to push towards primary care, towards the community, towards social determinants? How do you think about those challenges, those kinds of alignment?
Sure. Well, I'll start on the second part, which is about because you're a group of management people, and this is very much a management issue. What has traditionally happened in large systems like H&H is if someone wasn't very good, they sent them to the outpatient area. True. Absolutely. The doctors, the nurses, the administrators, right? If you weren't very good, right, they sent you to the outpatient area. Both the people who were not very good, and of course, even if you were good in the hospital, that wouldn't necessarily mean you were good in the outpatient area, which has a completely different tempo. And as you say, if you're a hospital administrator and there are 6 patients in the ED waiting for a vent bed, and you have 2 vent beds, and then there are 20 people who should be discharged, but there's no social worker, right? Are you really going to think about the patient care experience of the person who has the 20-minute primary care appointment? And the answer is no. And so I think that one of the things that was important to me was to bring someone who is like super enthusiastic as a primary care doctor to run primary care, and to get all of the other primary care people together and say, it's different. It's not better or worse, it's different. There are hospital people, there are primary care people, and there can be people who can do both, but when you're doing one, it's not the same. So I think as a management thing, making sure that the people running primary care understand primary care and understand the rules. And I'll give you one true example. The person I hired went around to all the primary care doctors and said, well, how can I help you? What would you like? And they said, well, we're upset that the majority of patients we see are not our own. It's like, what? It's like, well, because of the way patients are scheduled, it turns out that we sort of misunderstood some of the rules, or we had the wrong algorithm. If somebody called for an appointment, they were given whatever appointment was nearest on the theory that you should give patients appointments soon. Someone heard that. So the managed care companies, they want them soon, right, within 7 days. But of course, almost every person would rather wait a few extra days to see their own provider. And that's the whole point of primary care. I mean, as a primary care doctor, it's difficult. We're the ones who are always, asked to do the forms. We're the ones who, are the gatekeepers. The reason we become primary care doctors is the relationship. And if you take that away from us, there's no reason to be a primary care doctor. There's no pleasure in it. The pleasure is the relationships over time. So now, where they worked at Bellevue, they've completely turned it around, and 80% of the appointments are continuity appointments with the same provider. So all about the right management. On the other one, which is not entirely in our system, I think where I fall in is that as leaders, we have to do the right thing. So just to explain what Sherry was saying in real terms, hospital admissions bring big money. And while hospitals are expensive, the incremental expense of a patient can be very little, right? Because the hospital is open and running. So you got another patient admitted, no more additional staff, it's just pure money. And the incentives are so perverse in our country that even if the person is part of a managed care system and the admission is disallowed, you'll still get paid on the Medicare GME side. So that you're going to get a bunch of money. My view is we can't perpetuate the things that are wrong. If someone does not need to be admitted, they should not be admitted, and eventually the rest of the world will catch on. Where I do have to, I do think we have to be aggressive though about then getting every dollar we deserve. But I don't want us admitting patients who do not need to be admitted. And I do try, to the culture issue, people have been delivering these reports. Joe would have heard them, the board. We have bad news where, inpatient volume is down 3% and we have this less money. I'm like, that's great, right? We want inpatient volume to go down. We want primary care volume to go up.
So I'll just add on to that a couple of things. New York has done some interesting things, like the DSRIP waiver, which some of you are probably familiar with. I see some heads nodding, to incentivize working on social determinants, incentivize creating systems of care to care for vulnerable people and keep them out of the hospital. On a federal level, I still think the incentives are really going all in the wrong direction. And I look just at our short-term issues, and we do federal policy advocacy in Washington as a trade association. Sort of the movement to cut hospital outpatient payments is really going to create a disincentive, especially in vulnerable communities, to expand outpatient care. The things that are going on with the 340B drug discount program and sort of the opposition to that. Whether you like the program or not, undermining that program has a real incentive to disincentive around the kind of things that you're talking about. The administration says they're going to do some really interesting stuff that's going to change these incentives under Medicaid, a whole new payment model that's going to be rolled out in the next year or so. We heard that from the Secretary of HHS, just in the last few months. We'll see, what actually comes of that. All of us heard this morning, the administration filing a brief to basically strike the entire Affordable Care Act. Obviously, against that happening. I also don't see how taking away coverage from tens of millions of Americans is going to incentivize high-quality primary care. So I think the incentives on a federal level are still just not there, and there's some moves to go in the wrong direction, and we're going to have to change that to facilitate exactly this kind of work.
what could I add to that? I think that actually New York State, for those of you that are becoming acquainted with it, the healthcare policy in the state is really dominated by hospitals and their unions. And the idea that I mean, if we look at DSRIP, which had many good things about it, to be sure, it's actually sunsetting the end of 2019, and some of the larger institutions are saying, okay, well, that was nice, $9.2 billion plus dollars invested in the hospital system. There really has been almost zero, maybe 10%, I guess, because of the ACA increase in primary care reimbursement. Still very few incentives there. And then again, when half your patients are in a sort of neo-managed care format, Medicaid, arguably, I'll argue that a larger percentage are Medicare as well, but the other half are fee-for-service. It's very hard to change the culture in organizations because we don't want our caregivers to think about one's insurance source, and so I think it's a big challenge. Luckily, I think what Mitch is doing within H&H is a really great idea incentive, because you will realize the savings that you create in an outpatient system that may or may not be reimbursed in the way that the incentives are there for other institutions. So that's important. The other thing I just wanted to say, I always love this epidemiological number, which I've been remembering for most of my career. Kerr White did a really interesting study a very long time ago of people entering the formal healthcare system, people over 18, 30 days. Did you feel sick? Did you go see anybody? Of the 1,000 people that felt sick, 250 actually entered the formal healthcare system somewhere. And of that number, 4.5% ended up in a hospital. And all of the funding, all of the attention, all of the leverage is in the hospital system. It's really important to remember that, because we are really upside down. And that's from the UK National Medical Survey and the US National Ambulatory Care Survey, and Larry Green at CDC repeated that analysis about 7 or 8 years ago. If anything, it's more granular what we know about where people go. So the right thing is to really focus in the way you've heard about, but it's very, very hard to do because of really power structures and politics. But I'm sure you guys will cut through. You're the next generation. You have to keep pushing it.
Let me try one more question, and then I'll open it up to the floor. And this is about coverage expansion, and what does it mean for public hospitals to be operating in a world, let us imagine a world in which everyone had coverage, or even a world in which many more people have coverage. California has talked about covering undocumented people. Maybe that will happen in New York as well. How do you think about the role of the public hospital when so much of our thinking about it has been around people who don't have coverage?
I do think that's a great question, because it gets right to the core mission of why we should have public hospitals. Just for level setting, technically speaking, almost everybody in a New York City hospital today is covered. Because even if you're uncovered going in, you're going to get emergency Medicaid. And there's also disproportionate share dollars that you're going to get. So technically speaking, there is no problem around hospitalization financing. Of course, and this is what Joe was referring to. Now, is the same true if you need an outpatient? No. Right. Do the hospitals get paid? Can you use emergency Medicaid? You can use emergency Medicaid to take care to amputate your leg because you didn't control your diabetes. That's emergency Medicaid. Does emergency Medicaid pay for your insulin so that you wouldn't need the amputation? No. Right. If you arrive with the horrible infection, does the hospital have to see you if you're uninsured? Yes, under EMTALA. Does the specialist have to see you in follow-up? No. There's no EMTALA requirement for chronic care or for follow-up care. So in some ways, the role of the public system should be mostly about primary care and specialty care. The FQHCs are great, and they can do the primary care as well, but not the specialty. That's only the public system. So that's why I think it's such an important part. But beyond that, what I think, Sherry, is that I don't want to be a provider of last resort. I want to be a great provider. Then I have to ask myself, well, who could I be great for? And that's where I think I could be great at taking care of people with serious mental illness because I have 60% of the system. I could be great at taking care of people who are homeless because I have connections to the Department of Social Services. You can't afford to have a lawyer in every single hospital working on immigration issues, but we can because that's what our patients need. And so really have that be for New York the thing. It requires paying enough for, right? It's hard for me to deal with the finances of being the preferred behavioral health provider if the state only pays 60 cents on the dollar, but you make money on transplants, right? I mean, so I need some changes around that, but I see that as the key vision of the public hospital.
That's a beautiful vision. Go ahead.
Yeah, just to add, I think to Mitch's point earlier, I think the other reason for the coverage is one thing, but I think people do like to see providers who look like them, and there's nothing like that outside of HHC. There just isn't. And I think that, I mean, there are some, maybe a few hospitals that are so-called safety net hospitals in Brooklyn, but by and large, I think the corporation system, HHH, I have the same problem. I keep thinking of H&H Bagels with the new logo, but anyway. But I think the idea that, and the other thing that to me was so clear, and Mitch alluded to it early on in his talk, the people in H&H they can go other places. The people running the hospitals could make 4 times as much money somewhere else. And they're there because they care about it. And that's another level of culture that he has going for him to build on. And I think those are quite unique features in this environment. And I remember many stories of people, the 3rd generation of families using Kings County or going to Harlem Hospital because they trust it. They have issues, they critique it, Judy critiques it, others. But I think people really trust these institutions. So for some, it's first resort. And then the issue, as Mitch said, is let's make it as good as it can possibly be, which is great.
I look forward to a day when everybody has coverage. I also know that that's not going to mean we don't need these hospitals anymore. It'll make their jobs easier. But to think that we won't need them, that the rest of the system will take care of them, I think is very naive. And it's naive not to recognize the deep inequities that exist in the fabric of our communities, and the deep inequities that exist in the fabric of even our payment systems. So we can cover everybody, and that's great. But if we look at the history of the Medicaid program, one of the reasons we have Medicaid and Medicare is that on the Medicaid side, there was a decision made in 1964 and 65 that this system, which is going to cover poor people, mostly brown, mostly women at that time, we're going to let the states kind of run that. We'll set some guidelines. But for Medicare, we're going to have very strict centralized rules from the federal government, and by the way, higher payment rates. So those inequities, they exist on the policy level all the way down to the community. And our public systems, thankfully, are able to correct and respond to some of that in a very proactive way. But just covering everybody is not going to make that need go away. And covering everybody is not, unfortunately, going to be a signal to the rest of the healthcare industry to go to Southeast DC or go to the South Bronx or go to East Los Angeles.
Okay, I would like to now take some questions from the floor, and also people watching on live stream should send in questions. Oh, look, we have some questions here. Yes, sir.
Dr. Katz, I applaud your enthusiasm, and for those of us who have watched your career in San Francisco and Los Angeles, this is nothing new, so congratulations.
Thank you.
It's a pleasure to listen to you speak. Can you talk a little more about how you've saved the system money? I think it's $250 million while delivering superior health care at the same time. Can you talk a little more about how you're reducing the cost burden?
Sure. So trying to decrease expense to me is great because then every dollar we have goes to our patients. And so the biggest things that we've done so far, there's no joy in letting people go. But my focus is on doctors and nurses and social workers and the people who support them. It's not on managerial positions. And I do think that one of the management techniques, and I know, this is the home of the right answers for management techniques, which I may not have. I really like flat organizational charts. I don't believe in the sort of pyramids. I think that what you want is as little distance between the the head of a system and the nurse seeing the patient. And you want to, flatten things out. So we decreased, I think, at the end, it was about 160 managerial positions that we let go. We made a major decrease in our real estate. It's brought in a savings of $50 million purely by looking at how much space does it require that we work on. We have been looking, I asked people to give up cars, right? I mean, this is New York City. People can travel, right, in the best public system for transit. And well, I still think it's the best. I grew up.
Second best.
So I grew up in the D train. So I have very fond memories. We have found multiple cases where Health and Hospitals was running the same contract in 11 different versions. We're simply, by putting it together, we delivered dramatic savings. Health and Hospitals was not doing nearly as much as it could on group purchasing of pharmaceuticals, right? I mean, there are standard, things that you do, and what it just requires, I think, is a certain amount of discipline and a sense that it matters because it's another nurse, it's another neurologist, right? It's another social worker. And so far, we have been able to deliver quite a large amount of savings. Thank you.
Hi, I'm Elizabeth Wolf. I am a family doctor and I just recently joined Health Management Associates as a consultant. Mitch, I had a question. HMA.
Yeah.
Yes.
Good for you.
I know that you know Pat well.
I do.
Yes. I just wanted to ask, kind of along those lines of expenses, my understanding in reading some of your interviews regarding increasing revenues or profits for the health and hospitals is to increase primary care. Now, I know you spoke earlier kind of about potentially some cannibalization of the ED usage, but could you speak more? I know it's a bad term. Could you speak more about how does, in the models I'm familiar with, primary care does not increase profits. It's usually a negative profit. So would you speak to that, please?
Okay, well, first I'm going to start because you're talking about revenue. I'll just say, when I first came here, they told me that there was a $1.8 billion deficit for health and hospitals on a $7.5 billion base. Now imagine what kind of crazy person would leave sunny Los Angeles, where it's always 75 degrees, to take over an organization which is purported to have a $1.8 billion hole. So 300 million got resolved with the dish, and then it was 1.5. So you deserve some credit for that. I don't get any credit for that. So now I'm at 1.5 billion. I assume that this is because we take care of all of these uninsured patients. But then I'm like, well, but wait a minute, with emergency Medicaid, everybody in the hospital is covered, and while, Bruce, Medicaid is not adequate, it's a hell of a lot better in New York than it is in California. Yeah. And I left California with a $585 million surplus through the ACA years, right, instead of the $250 million deficit I found. So I'm like, so it can't be the outpatient care. First, H&H doesn't do a lot of it, and second, that's the cheaper part of the care. So that's where I discovered that mostly we were subsidizing insurance companies. We were not billing for our services. We were not doing all the level steps. We weren't collecting the card. We weren't doing the prior authorization. We weren't coding the records. We weren't sending the bills. We weren't appealing when they didn't pay, and we had horrible rates. Just again, because I'm on a tirade this week about health insurance. I got insurance with my Cadillac New York City job. I chose an insurance company that would let me see doctors at H&H while also covering my children in Los Angeles. So I couldn't join our health plan because I needed to cover them. So that plan, they send you what they pay. For my primary care appointment, first visit, my Cadillac insurance paid H&H $42. right? No system could break even on a primary care visit for $42 first visit, right? I mean, you not only have the doctor time, but the time for the, the person who put me in the room, right? And the overhead and the billing and right? So actually we're subsidizing city insurance. I mean, so a lot of the revenue has been about fixing that. And we brought in $150 million last year of new patient revenue, not sort of the lobbying we do with Bruce, but pure billing insurance. And this year, on top of that 150, we have another 60 million. So I think, so that's the big revenue. I really see primary care as doing the right thing. I do think in our system, just because we are so far on the side of send people to the ED, that we will see some savings. I agree with you that if in a well-functioning system, you start just adding primary care, you're going to mostly add expense. But you have to remember that other systems 25 years ago started saying, don't go to the ED. Well, we still say go to the ED. So I think there will be some savings. I think ambulatory sensitive hospitalizations will go down.
Hi, my name is Detta Howard. I work in healthcare quality. In 2017, there was a bipartisan law, the MACRA law, Medicare Access and Chip Reauthorization Act, that was introduced. I see a lot of primary care doctors and specialists implementing the MACRA and MIPS program. So I just want to know from the side of the hospitals, how, if you're implementing the MACRA law, how is it helping in the management of quality and costs within the hospital systems?
Bruce, can you do better than me on that?
I think there's been a bumpy road in terms of, well, moving physicians and physician practices and the outpatient arena to perhaps the same platforms around quality as many of our hospitals and hospital-based systems have had. I think we've come a long way. I think meaningful use laid a lot of that out early on. I worry a little bit, and I'll make a vaguely political comment here, that this administration has been less focused on accountability and measurement in the physician field as opposed to the hospital field. I felt, a few years ago we were moving towards convergence in these areas, common measure sets, common expectations, common platforms, and I think we've seen in the last couple of years, through CMS, some sort of backing off on the physician side. I won't talk about what the motivations might be there. There's policy and politics as well. So I worry a little bit about our losing our focus on that movement to accountability. With all that said, and I'll just say one last thing, we measure a lot in healthcare in America. We measure a huge amount now, and I think that's a good thing, but I'll just present two caveats to that. One is there are things we probably need to stop measuring that we've gotten better at, and I am happy to see that the federal government is now starting to look at and thoughtfully retire things that don't make much sense, and moves away from very small process measures to much larger outcomes measures. I think that's the right thing to do. But when you do that, you got to think about risk adjustment for vulnerable populations. The more you move to outcome measures, whether it's mortality, readmissions, total cost of care, you've got to take into account the social risk factors that the patients, especially Mitch's patients, must encounter, and how that affects those outcomes as well. Because if you don't do that, all you'll basically will do is essentially redline systems like New York H&H and essentially financially penalize them, and even more so, send an economic signal that there are communities in America where providers should not go because they'll essentially be punished for caring for those populations. So, long answer to a short question.
Hi, Judy Wessler. I'm a longtime community health advocate. And HHC, which I will always call it that, for once, went on the offensive instead of the usual being defensive in a system that doesn't pay the kind of respect that it should to the system. In terms of what to do with what some people call the indigent care pool, we call them charity care dollars. And instead of just sort of fighting for themselves, which is typical, came up with a proposal with community and labor, at least the public sector labor, not 1199, to actually fund the public system and safety net hospitals and move monies around in a way that it wasn't just for one system, but was for all the hospitals that were actually taking care of uninsured and high Medicaid. And what I call the pigs at the trough have stopped it at this moment, but doesn't mean that we're going to stop fighting for it. But perhaps Dr. Katz could talk about, that perspective of doing things differently. And I'm sure Bruce and Joe and Luis know, how hard it is to be on the offensive in this system. So just as a compliment, but also a question about, how you see that going. We haven't won yet, but we ain't giving up.
We're not giving up, Judy, and Judy has been a great advocate for the uninsured. So, again, just so everyone has the same information, there's a program called the Disproportionate Share Hospital Program, which is meant to pay for the care of patients who are uninsured, number one, and Medicaid, number two. But the important part in that, and it's where I think New York State has gotten it wrong, is the word disproportionate. So the program right now is more like pro rata. So you do some, you get some money, right? And the idea of the disproportionate was that, well, if you do only a small amount, that's because you have a lot of patients who have Cadillac insurance, and so you can afford to cross-subsidize, that the money is really meant for those hospitals that are doing the disproportionate share of the indigent care, not just per rata, because you're a very big system, and so you have a sizable number, but it's a tiny percentage. And Judy and I and others have been trying to get the state to change it, and we got close, Judy. And I haven't given up. I mean, we had a bill. The assembly put in language. We're close. I think that right now people see it as that they have to do something, but we didn't quite get over the activation energy yet. But Judy and I are going to keep fighting at it.
For at least 4 decades, I've heard that Americans pay the most for health care and get the poorest outcomes compared with all the other advanced industrial countries. The fellow who's the head of HHC, you said that you don't pay attention to the buying drugs, in a cost-efficient way before. There's a talk about having single-payer health care. And how do you feel about that? Are we so committed to market enterprise healthcare that socialized medicine is completely out of the question? And are we committed to maximum inefficiency?
Well, I can ask Sherry to have a whole forum, if you haven't already, on single payer and universal. But a few thoughts that I have. I'd be fascinated at what Bruce and Joe think. So, as a physician, there's no question that a single payer system would be great. No question. And just, a tiny story. 3 weeks ago, I'm seeing a patient, try to be a first visit, try to be patient-centered, focused on what he wanted. At the end of the visit, he says, "Could you please renew my medicines?" I say, "Fine, happy to do that." I write them all down. I send him on his way. then when I'm going to do it, because I will not do the electronic health record while I'm seeing patients. I can't function that way. I like to talk to my patients, then I do my paperwork. I do the medicines. He's on a medicine which his new insurance formulary doesn't support. So here he is, he has controlled blood pressure, but I have to change his blood pressure medicine simply because of insurance issues, right? Which is not at all patient-centered. And meanwhile, I already told him that I was going to refill his medicines. And so now I think he's going to go to the pharmacy, he's going to find a different medicine and think, what kind of doctor is that? Right, I asked him to refill my medicine. Without even telling me, he puts me on some other blood pressure medicine I've never heard of. I mean, how could you respect a doctor who would do that? And because he had controlled blood pressure, and I would add, there's no conversion between the medicine he's on and a medicine I had to prescribe. And that's just because of the dysfunction of our system. It has nothing to do with money. It purely, well, it does. It has nothing to do, his drug was not particularly expensive. It's just that every plan gets the best price by negotiating what's on their formulary. So I say, if you give me a reduction, I'll put your drug as number one. But then when you do your negotiation, it's with a different, so you choose a different drug. And so now we're all wasting our time destroying his regimen for no real purpose. And to me, it perfectly captures. I think there was a very well done article in the New York Times this week about single payer, which just points out the obvious of how hard it is to get from here to there. And that's true. And whether or not we have the political will to do it, whether we have the gumption to do it, it's very hard to see how we get there, even though from my point of view, it's clearly the right place. So Bruce, do you think we could get there? Do you think there's a road?
I'm going to ask Joe. No.
Well, we will ask Joe.
I'll just, a couple of things. I have to be careful because I have a day job. And our,
I have a day job.
Yeah, well, you work for some different people. Our association has not taken a position on this, and we've had active discussions about this. And there's a lot of politics in D.C. going on about this right now, between the Democratic primaries and that debate. I think the indications we're getting from the leadership of the Democratic House is we really don't want to talk about Medicare for all right now. They've been, we've gotten that message very clear, and they have their political reasons, and I understand that. Personally, my sentiments were probably closer to Mitch's, but I'll leave it at that. I think it's going to be hard to get there, and I don't say that's why we shouldn't even try, but just the amount of capital that's invested in what we do today, and we may not, whether we like it or not, it's there. There's so much investment in this system with this dysfunctionality that getting us away from that is going to take a while. I don't think it's impossible. I don't think it's going to happen in one fell swoop, though. I think it's going to be, a years-long, maybe even decades-long journey. But I do think when you're in a system which delivers not good outcomes, consumes 70% of GDP and rising, and in which consumers, dread opening their EOB from their insurance company. And I'll say I do because, my daughter had an ankle fracture in Philadelphia and went to the ER, went for follow-up care. And I think I know this stuff. I cannot figure out who's billing me, what they're billing me for, what the copay really should be. I called about one bill and found out, ignore that because really they put in something wrong about the provider, so that's why we denied it. But didn't tell me that on the EOB. I spent hours working on this. There's got to be a better way than doing this. It's just a shame.
Yeah, I endorse both of what you said. I think the other thing we forget that the Accountable Care Act, or Affordable Care, whichever you want to call it, ACA is the first time this country's had a federal national commitment to universal financial access. Really, really important policy step. Never happened before. And the first time federal dollars were ever invested in prevention. Really important point in its own value. The finances is another thing I'm not going to go into. I don't do it anymore. I can't be helpful. But I think the universal financial access is, we have been there as a value system, and we really need to remember that when we're arguing for universal coverage. I loved your question because you said it exactly right. Why do we invest so much in health per capita and get so little health result? The reason is we're putting it all in the healthcare system. And the data is there, that the National Academy of Medicine, many reports showing that 95% of all of our dollars in the health sector go into healthcare, to specialty medicine and biomedical research. That's fine. It's probably the best in the world. The biomedical research, maybe not the other, but it's pretty darn good, and most people would want to come here. I think we'll see a lot of that tourism. But the less than 5% are in public health and prevention. And if you look at Betsy Bradley's work, who was at Yale when she did this work, looking at the proportion of health and social care to each other, the United States spends about $3 for health care for every dollar it puts in a social support system. Now we're discovering social determinants wrap around, for people. And in Europe, it's the opposite. It's $1 in health care and $3 in social supports. And when I say social support, I mean education and food and schooling and housing and economic development. So those are the data that answer your question. And I think even though we will get universal coverage at some point, and we talk about if you take the 30% of the administrative overhead, you have Canada. But anyway, those are long stories, they're old stories. So we have to keep pushing there, but we've got to begin to have people aware of where health comes from, where health outcomes come from. And it's not only in the healthcare system, it's got to be both.
So I just want to add one thing to that. So I spend a fair amount of my time on the road, and very often I have leaders of our essential hospital systems, clearly worried about their future. And they'll say to me, we're always being forced to do more with less. And I understand that perspective. I've been there. But my response to them is, actually, the challenge for you is to do less with less. And I mean in terms of less intensity, less waste, less redundancy, less, doing things that have little value, fewer emergency room visits and fewer hospitalizations, and more high-value things like primary care. If we can start to do that, then we can start to address some of the issues that Joe is talking about, which is how we our allocation of investment is so wrong in our social and healthcare systems in this country.
Can I just one other comment I think that's really important? Of all the OECD countries, the high-income countries in the world, the U.S. is very down the bottom in many indicators, but we've had a reduction in life expectancy for white men because of the opioid epidemic, which people know about. Many talk about that epidemic as an epidemic of hopelessness. And I think the psychosocial, the behavioral issues are really there. And then the other important part of this conversation, I think, is just really beginning to realize that this is happening across New York State, north of Westchester, in case you're interested. There are a lot of coalitions of local communities without any funding coming together, led by hospitals as anchor institutions, performing this role that's been written about, investing their community benefit dollars, working with local health directors and other groups in local coalitions in all the counties across the state of New York, looking at priorities for prevention and also priorities for addressing health disparities. It takes time to develop that infrastructure, but it is there. It's really an opportunity, I think, that we can build on in looking at how do you do things with less when you have that the community opinion leaders and influencers really working together towards a particular goal, a shared goal.
Good evening. My name is Lynette Swan, and I am currently the proud Director of Patient Relations at New York Health and Hospitals Woodhall. And I'm not trying to suck up, but I really need to thank you, Dr. Katz, for the work that you're doing.
Thank you.
Your strategic vision is well communicated, and you're bringing everyone, all the different cultures at all the 11 different facilities to make it more of a system. It has more systemness than everyone working in silos doing things differently. So I just wanted to personally thank you for that. Thank you so much.
Thank you. Very kind of you. I appreciate it.
And now we've got, all right. Actually, the person there has, you were.
Closer to the mic.
Yeah.
Hi, I'm a physician from Canada, and I'd like to contribute my perspectives from one who lives and works in a single payer system, which is our government. We are grappling with serious challenges. I'm from BC, a family physician. I would caution you that to look at single payer as important as universal coverage is, but that's not the only route to universal coverage. I would caution you to look at that as the panacea. I think it's important that we learn from the experience of other countries. Certainly Canada and the US have a lot of similarities in how we practice medicine, many cultural similarities, but really it's important to understand the context of our healthcare systems and the evidence for how we create value and quality rather than replicating each other's mistakes. I would say that as a family doctor working in British Columbia and Vancouver, we are paid, instead of $42 to see a patient, we're paid $30. And our system of family practice is in fact close to extinction, just simply because we are subsidizing the public healthcare system, which is our government, with fees that we have no private system and no ability to extra bill. So just a cautionary note that evidence-based policy is fundamental, and really the devil is in the detail. Single payer on its own as a public insurance system is not a magic bullet.
Thank you.
Thank you.
Jenny.
So just to continue and sucking up to Dr. Katz. I'm a psychiatrist who's worked in the H&H system for the last 10 years, basically because it really is the only place you can work, because it's the only system that has any kind of commitment to psychiatry. It is such a pleasure to hear you're going to do something about the rates. Because what they did in behavioral health about 8 years ago was they systematically dropped the inpatient rate, so it doesn't cover its cost, as you say, and they've never paid enough for outpatient. So congratulations on, and 4 out of the 5 discharge diagnoses across H&H are behavioral health. So we've been handed that population by a state who hasn't paid us adequately to do the work, and I'm glad you're going to deal with that.
Thanks, Jeff.
Thank you. So over there in the corner.
Hi, Dr. Katz. I'm one of your frontline doctors. And I think everybody up there has circled around the idea of social determinants of health, but nobody's really talked about how, as a healthcare sector, we can address it. For example, where I work at Gouverneur, I'm working on a project to screen for social determinants of health. And that part is easy. The hard part is, what do we do when we get a positive screen? Right. And right now, our plan is to spit out an automatic computer-generated list of, for example, food pantries based on your zip code. And that's the best we can do, is hand the patient that piece of paper, because there's nobody to call them to follow up. There's nobody to troubleshoot if that food pantry is closed to help them find another one. All there is me, and I'm busy seeing 20 more patients tomorrow with the same list of problems. So I don't know what the answer is, but we don't have anybody to do that. I have a very good nurse. I have a pretty good medical assistant, but I would rather they're doing asthma education or triaging the patients for the day, not doing that.
So I think that's a well-stated problem. But I think we are going to do stuff. So I think the Now POW, which is what you're printing out, it is a positive thing. And excuse me? Better than nothing, right? And it again, as a tool, right? It's the right thing. At least tell people where they can go. But what I imagine as part of a culturally competent health and hospitals is a large care management presence, and that the majority of people that we see would have a care manager and would be managed in teams depending upon whether they're high need or moderate need or low need. and that we would not, as physicians, right, we're actually the most expensive, right? We need you to diagnose and treat illness, right? And it's great for you as part of that to diagnose problems like homelessness and housing, which we know contribute to illness. But then we don't want to pay you to, try to figure that out. So that's how I think, and we are much closer. Dave is going to roll out at a variety of meetings a system-wide H&H, because I keep saying to Dave and to others, I don't do pilots. I do ramp-ups, but I don't do pilots. Right? You can't do, with a system like ours, you can't do everything at once everywhere. But I want a ramp up. I want to start in one place with the idea that everybody who needs care management will get it. So my hope is that if we're talking about this in a year and a half, it will be different.
Great. Yeah, can I just say as a complement to that effort, an important one, I wanted to mention, especially for this audience, the issue of community benefit, which is an obligation that voluntary hospitals have to the Internal Revenue Service to maintain their nonprofit status. In New York, there's been an effort the last 3 or 4 years to really raise more attention to community benefit. There are 9 categories of community benefit. One of them is called community health improvement, which if you look at the category in New York State in 2015 was $340 million in one category. This is not graduate medical education. It's not disproportionate share. It's not all the things that hospitals depend on, that teaching hospitals depend on. It's a set of things that hospitals are, many of them are now investing in community activities, community health related activities. It's a lot of money. And from a public health point of view, that money, you're not going to get that money from the healthcare delivery system because they need it for some of the reasons you're talking about in these new systems they haven't mastered. But I think part of this broader determinants of health beyond the individual patient and looking at conditions in communities, there's funding in other sectors. There's money in the housing sector. There's money in the transportation sector. There's money in education, these other areas that can be leveraged to improve conditions in communities. Hospitals in the healthcare sector, we have no experience doing that. Part of DSRIP was the idea that we would create partnerships, hospitals would create what I call the front-end partnerships with community-based organizations that keep people out of the hospital, where they're pretty good at connecting with the long-term care related to move into long-term care, home care, et cetera. Very new experience, very difficult, very challenging. Most of the resources did not end up there because there was so much restructuring that needed to be done around the coordinated care that Mitch is talking about. But I think we need to, as healthcare professionals, think about partnership issues. We always, I'm a pediatrician, so I speak about doctors and other people running healthcare systems. We always think we have to do everything ourselves, and we don't. We have to find partners who do the stuff that we need to have done for our patients or for our communities, but do it a hell of a lot better than we do because they have experience in it. And then we have to figure out how to work with them to get resources to make it work for the patient. So I just want to use that as a little opportunity to mention community benefit. Any eager students, please look it up and see what it means. There's a very important area of advocacy there that you can jump into.
So I want to echo some of Joe's comments, but also add something. Around the country, so many health systems now have a vice president or senior vice president or executive vice president of population health. And I often ask folks, so what are you doing around population health? And one place is, well, they run the ACO. Another place is, well, they're dealing with partnerships around food insecurity. It's really,
they're managing their diabetics.
Or they're managing diabetics, panel management.
Exactly.
These are all really different things. Yeah. And I think part of the root issue here is that many systems have not defined what their journey is going to be or their direction on population health. And until they do that, really, it's hard for them to define, what's the human capital they're going to need to sort of, to figure that out. And this is self-serving. We just did a report on this at our association, but we really were struck by the diversity, maybe the chaos that is still going on in this world. And everybody's going to need to sort of get their arms around it and decide for themselves what this actually means. Because right now, a lot of places, folks are kind of boiling the ocean.
But I think also that we've used the term social determinants of health. It's come up multiple times. It has very different meanings in public health than it has for the clinicians, and they're complementary. So we're focusing social determinants of health, as CMS would define it, and as they've been trying to promote it, is really creating a set of services around an individual. And from a public health and broader population health perspective, it's really about creating conditions in communities in which those individuals live. And that's a very different set of interventions and very different set of partnerships. But they both have to happen.
So I'm going to take the moderator's prerogative and ask the last question, which is, we have a lot of students in the room. I see lots of my students down here and quite a number of faculty. What single or couple of pieces of skills or knowledge do you think we really need to equip our students with so that they can go out and work with you to do the things you want to do? There, that's an easy one.
Well, on the managerial side, because this is a school of management, I do think, and I appreciate this much better now than I did 25 years ago, that running organizations is about relationships. It's about understanding other people. It's about engaging in other people. The analytics are really very minor, right? Because there are only so many ways to do things. And besides, if people don't like you and don't want to work with you, it doesn't matter what you say. It really doesn't. People want to relate to you, and you should want to relate to them. And you should want to understand their problems. And that I do think in management, paying attention to empathy, paying attention to how other people are feeling, what their experience of patient care or working in a hospital is way more important than the analytics. I do think the analytics matter. I just think that we've weighed them wrong. For the other, what I always look for is people who want to make a difference, right? The downwardly mobile, the people who want to pass up on the higher paying jobs because they know that happiness does not come from earning more money. And this has been studied right beyond, I think the threshold in the U.S. is like 85,000, right? After that, right, after you've met your needs, right, happiness comes from the people you love and the work you do. And so if you want a happy life, love someone great, have a family with them, whatever family means to you, and find work that has meaning. And no one in New York in the healthcare sector has a better mission than H&H. We're somewhat chaotic, but we have a phenomenal mission and a big heart.
Thank you very much. I think we cannot possibly close with anything better than that. So thank you all very much for participating this evening and for your very wise remarks. And thank you all for coming.
Bruce, nice to see you. Yeah, go ahead. Sorry. So you'll be posted about.